There's some profound data in here. Some of it we've already seen, in that a significant number of patients, and this data point from the Joint Commission's lit review indicated that anywhere from a fifth to potentially even half of all patients admitted for any medical reason have a behavioral health diagnosis, or presumably they would qualify for a behavioral health diagnosis. So we've kind of seen that data point in other articles. What we haven't necessarily seen, and one of the reasons why I wanted to highlight this, is that according to the data that the Joint Commission looked at, the rate of psychiatric consultation, meaning a behavioral health specialist of some sort, speaks to actually conducts an assessment on people in a general hospital setting, is less than 4%. So generally, the way it works in a hospital, generally in a general hospital, is that a referral for a psychosocial assessment by one of us, or a psychiatric assessment by a psychiatrist, is really only done at the request of the attending physician. And certainly, if you're a social worker on a general medical floor, you can certainly, and I did many times, advocate with the attending physician to have a psychiatric consultation. And generally, at least in my experience, what I recall a time ago, was that attending, if you brought it to their attention, they were fine with it. But it really, a lot of times, is purely uh, the attending noticing that the person needs some sort of behavioral health assessment. And according to the data that the Joint Commission had, that happens less than 5% of the time. So lots of people coming into the hospital with behavioral health needs, very few of them being assessed for those needs, is the primary data point. And another example of how poor behavioral health integration and behavioral health care access is as bad economically as it is from a human standpoint, is patients with psychiatric comorbidities. And the way this reads in the article is, even when they are addressed, and they're one of those less than 4% who actually get a formal assessment, either by psychiatrist or assessment by social worker, they still have, uh, using the author's words here, significantly longer length of stay and increased risk of readmission. And these are things, as we know, cost a lot of money. So we've seen this in other articles, and it's interesting to kind of compare and contrast the nuances of these definitions of integrated care by authors of various journal articles. But we see, the shared responsibility, um, the in the case of acute care, one of the things that in terms of the Joint Commission and the way they define integrated care, is that the behavioral health team is a constant physical presence as part of their kind of the part of their definition of integrated care, which is different than some of the other definitions we've seen, where uh, we've seen some of the authors of different journal articles say, well, it can be co-located or it can be not co-located. It's just interesting to note from the authors of this article standpoint that if we're talking about a general inpatient setting, that the physical presence is required. So this idea of reactive versus proactive in a general inpatient setting is consistent with what my experience was when I worked as a quote unquote medical social worker. Reactive meaning simply that there has to be something that causes the attending and oftentimes the behest of a social worker on the unit. Uh, but something has to draw the attention of the attending physician to then pull in by a doctor's order some form of behavioral health assessment and care. There is generally no kind of proactive um, screening for behavioral health, and which is interesting because um, there are other aspects of medical care, when most folks have basic lab work done. No one passes through a hospital without basic blood work in most circumstances. So there are examples of proactive um, care, and general lab work being one of them. So just to underscore the point here, you can call this data point, the way it often happens, reactive, and this proposed way of doing it, proactive. Uh, the other thing here is that traditional medical training, absolutely, and one of the reasons why we have this course, right, is that historically um, medical providers, certainly medical school, if not nursing and other uh, disciplines of health historically, uh, have not talked about integrated care and the impact of not just mental health or addiction on a person's overall health, but the impact of psychosocial stressors and social determinants of health on people's physiological health. So, and that's something we're starting to move the needle on, um, at least in some disciplines, and certainly, like we've talked about on the message boards, UMB, our institution has really started to address that in these interdisciplinary study programs that we have across institutions like our school and the nursing school. So this concept of curbside consult is probably why the authors of this study um, define integrated care in the acute, in inpatient hospital, medical settings, as the co-location is required, and that certainly bears true with my experience. I certainly did when I worked in hospitals, uh, in general medical hospitals, did many curbside consults for sure, and certainly even the ordering of formal assessments often, in my experience, they wouldn't have happened if I didn't happen to be on the unit, sometimes attending to a different patient. And there were times where a patient just called me over, either in the hallway or uh, coming in to see someone in a patient room, and the patient, in a shared room. Patient just sees me, hears me introduce myself as a social worker, and they're like, "Hey, can I talk to you?" And a lot of times that would be the impetus for someone getting the assessment and the follow-up care that they needed. So, like with Dr. Satcher's group, uh, the researchers here, the participants in the study, also provided education as well as behavioral health services. So, um, really important, of course. It's especially in that. When we continue, as far as I can tell, to generally rely on the clinical judgment and the awareness of an attending physician or nursing staff uh, for for a person to get access to a psychosocial assessment or a psychiatric evaluation. Um, this education and collaboration piece, really super important, as is the follow up. So certainly, uh, follow up within the inpatient stay is uh, can be important and helpful and may have a positive emotional psychological impact on the patient as well as actual treatment and care, both pharmacological and non-pharmacological. And then, of course, uh, perhaps even more important than that is the uh, follow-up after discharge and the timely follow-up after discharge. It's critically important. So thinking back to the data point at the beginning of the article where potentially half of all people who come in to admitted to inpatient care for any reason have behavioral health, using their words, behavioral health needs. This is exactly what, according to the authors, they found when they started doing proactive screening. So when they went to that from reactive to proactive model in just a 6-week pilot, um, half of those patients that they encountered over this 6-week pilot period had behavioral, were found to have behavioral health needs. And and this is really again where if you're advocating to policymakers who don't seem to have to really get the human piece of it, this is profound when you talk about the cost of a single day of inpatient care in almost any part of the country is many, many thousands of dollars. So to have this proactive screening program, which pays for itself in maybe 10 saved days of inpatient care, the 6-week model, when you talk about potentially up to $10,000 a day depending on where they are in the country and what exact type of care that they're getting, what unit that they're on, what level of unit or care that they're on. This is just truly profound, and certainly anybody who cares about the idea of standing up a Medicare for All program to do things, to have programs that pay for themselves exponentially in a immediate, right, is I would think would be a very powerful uh, advocacy tool. So as part of their study, the authors organized and documented 5 key barriers to integrated care based on their experience in this pilot project and in their research. So what's number one? The business case, right? Uh, and that, saving 1 point whatever day on the previous slide, that alone should be a pretty good business case because like readmission markers for Medicare, if not Medicaid and other health plans, um, the length of stays are watched very, very closely by those payers. And there is a lot of, most hospitals expend a good amount of resource collecting and reporting out that data because it's watched very closely, especially by CMS. So the concept of physician resistance, 2 ways to combat that. One is to in these grant-funded efforts to have education and frankly just peer support and collaboration as part of the as part of the. In addition to this, also underscores the importance of, from an educational standpoint, of pushing forward these interdisciplinary programs and getting these, particularly in a institution like ours, where we have, not just these different pillars of health and very esteemed um, education programs, schools for each of them, but they're also co-located. We have a medical, a large hospital, geographically in the middle of the medical school and the nursing school and the pharmacy school and the social work school. So there's a lot of opportunity to combat this, or combat's the wrong word, but to move the needle on this in a positive way. at the education level. And obviously communication, this is something as social workers, it's part of our kind of our kind of our core one of our core talents generally, and one of our core missions is to be the glue that brings and holds groups together, and that is certainly the case in interdisciplinary integrated care, like in a inpatient medical facility. So two, in my opinion, very good points here. One, and if any of you are working or have worked in hospitals, you know that there is constant chatter about length of stays and shortening length of stays and getting patients out of the hospital because we're worried about the length of stay. So getting that intervention, and I remember that's from even from 20 years ago, being in the hospital where trying to one, get the attention of the attending before they're discharged, and then making sure that consult goes all the way. The consult gets ordered and implemented, conducted before the patient is discharged. And this underscores the need of a proactive approach, screening people as part of part of the process as running basic lab work, for taking blood and running basic lab work, for example. And again, this is a huge one, probably worse than ever in terms of the level of challenge. Timely outpatient follow-up. The number of providers does not. We don't have the supply to meet the demand in most areas of the country, and the downstream effect of that, juxtaposed, laid up against our current state of our healthcare system, where one of the end results is that providers, social workers, LCPCs, other behavioral health professionals, uh, even if they are available, they don't take insurance, and thus make themselves inaccessible to many people. Really creates a very challenging aspect to this, because without timely follow up, all this other stuff is um, uh, negated, if not nullified, in my opinion. So when here, and can't argue, against their point that the way they lay it out is that in the acute medical setting and inpatient medical care, co-location is a really much more of a requirement than a nice to have, as opposed to perhaps a traditional primary care setting. So one of the things I think this is pretty self-explanatory, but one of the things that I kind of start with in my health IT policy class with my graduate health IT students is this this challenge, helping them understand that one of the challenges the providers that they support as health IT managers or health IT implementers is that providers in an acute care setting are increasingly distracted with technology, with electronic medical record, trying to do data entry while they're talking to patients, and all of this just gets away from uh, the critical importance to have eyeball to eyeball contact with a patient and really hear their story, not just their list of symptoms, but what is going on with them in their own words. And as we are pulled further and further away from that, because and I'm empathetic to those in a hospital setting, they're so pressured for time and to move folks in and out, um, that it can be really hard to focus on the patient as a person. Interestingly, one of the things they do at Frederick Memorial Hospital, or now just called Frederick Hospital, uh, is they actually have a data entry person. So when the PA or um attending physician comes into the patient room, they're actually followed by a data entry person who rolls up with they have the computer kind of set up on a cart, and that person does the data entry while the PA or the physician has a conversation with the patient. So I saw that very recently, and I thought that was interesting. I'm sure they're not, and I would hope they're not the only ones doing it, but it was notable. Anyway, so one of the things to just keep in mind as social workers when we're still in a kind of reactive system of, oh, okay, well, we'll pull in behavioral health if if it crosses our attention. um, we have to remember that our providers, particularly our PAs, nurse practitioners, and physicians, are increasingly distracted with healthcare technology and data entry. So I thought this was a useful list here in the middle of this slide. This is a list of common concerns found by the authors to address when educating non-behavioral health providers about behavioral health integration. So legal, privacy, kind of management decisions, logistical decisions, billing, of course, we've talked about a good bit, and of course, cultural issues. Um, Part of that can be just the way of doing things without behavioral health integration, as well as stigma and other related issues, misperceptions, generalizations, stereotypes about treating mental illness and addiction. So I think that's a really useful list. So just a point of clarification here. Somehow this particular line got kind of butchered when it went through the spell check. So, additional reasons why we should make staff education a priority, uh, and those include uh, ambivalence towards patients' behavioral health needs, a lack of empathy towards patients with behavioral health needs, a misperception that behavioral health needs are always less acute than physiological needs, and that patients with because hospitalization is generally short, that there's no time to perform a behavioral health intervention, and so it's important to remember that just like all inpatient, we don't admit people for any physiological reason to the hospital with the idea that we're going to completely resolve whatever that particular condition is at that particular time. Is provide immediate intervention, intensive therapies, and then get people into longer term treatment and recovery outside the hospital. And behavioral health is functions no different in that way. So I guess part of all this comes back to helping non-behavioral health specific providers understand that behavioral health is every bit a part of whole health and medicine as any other physiological aspect of a human being. So I think this slide reiterates the business case for integrated care. Uh, as we move more and more into value-based care, or care being paying facilities and even individual providers based on outcomes versus solely on volume, it's going to heighten the financial or economic value of treating the whole person, including behavioral health and social determinant issues. So this is another place where, thinking back to our our lecture on the Affordable Care Act, and which is really kind of the federal impetus for uh, turning the healthcare industry away from purely fee for service by volume to at least some uh, payment and financial exchange based on outcomes, just heightens the importance and increases the value of integrated care, in my opinion. So, some other cost-saving measures by having better integrated care. Here's another one that wasn't mentioned before: use of sitters. Those individually are not necessarily high-cost items, but when you are utilizing those services at a significant volume or volume over time, those costs can add up. And generally, if you're having to use a sitter for to manage behavior, then probably falling short of providing good, sound behavioral health intervention. Not always, but a lot of times, in my opinion. So, reducing length of stay and being able, as we saw at the very beginning of our course, opportunities for more billable time. Again, so for those persons in our continuum of stakeholders that are not terribly focused or maybe solely focused on economic and not at all focused on the human aspects of this, there is plenty there for them as well.